So today we will be talking about neonatal cholestasis, and what is important is to recognize when to suspect cholestasis in an infant. You have a newborn who may have exaggerated physiological jaundice, may have breast milk jaundice, and you just tell them to wait and watch. So any jaundice in a newborn that persists beyond 2 weeks of age, there's associated hepatomegaly, may or may not have pale stools or diarrhea, you have to suspect neonatal cholestasis. So whenever you have a child who comes with jaundice, newborn, beyond 2 weeks of age, ask for color of the urine, whether it's high colored urine. Look at whether there is any liver palpable or not, and ask for history of the stool color, whether it's pale color or not. When you now find that there is jaundice, hepatomegaly, what are you supposed to do? First, check the serum bilirubin. Look at the direct and the indirect component of it. That is the conjugated and the unconjugated bilirubin. Now, when will you say this is neonatal cholestasis and this is not neonatal hyperbilirubinemia? When you have a direct component of bilirubin more than 1 if your total is around 5 or less than 5. If your total bilirubin is more than 5, then your direct component should be 20%. There will be high colored urine staining the diapers, and there may or may not be clay colored stools. So this is your definition. Now what happens is, a lot of times you may see newborns in the NICU and they are not even 2 weeks of age, and you get a reference saying that this child has jaundice and it looks direct. So how do you recognize direct jaundice in less than 2 weeks of age? When will you say this is neonatal cholestasis? So there's this paper which I came across that has determined these values in newborns in the first 5 days. So in the first 5 days, if your conjugated bilirubin is greater than 0.3 to 0.4, or it is above the upper limit of normal for the laboratory, or it is greater than 10% of the total bilirubin. So in more than 2 weeks, we are looking at 20% of total bilirubin. But if your direct is more than 10% of the total bilirubin, in newborns up to 5 days of age, then you will consider it as neonatal cholestasis. Now, what is the incidence of or prevalence of this neonatal cholestasis? Worldwide, it is reported to be something like 1 in 2,500. In India, of all the chronic liver diseases in children through various hospitals, the reported incidence of neonatal cholestasis is almost 19 to 33%. So that means 1/3 of all your chronic liver disease in pediatric is because of neonatal cholestasis. So you need to really know how to deal with these patients. Now, there are various causes of neonatal cholestasis. You have obstructive causes, you have anatomical causes, you have infections, toxins, drug-induced, endocrine causes, you may have metabolic causes. What is important to remember is the treatable causes of jaundice. So if you look at anatomic, most common is biliary atresia. Of all your neonatal cholestasis, almost to the tune of 25 to 40% will be biliary atresia. And what's the treatment for that? Kasai's portoenterostomy. Choledochal cyst, again you go in for surgery and remove the cyst. You may have a spontaneous perforation of the CBD, then you need to do a surgical drainage or a stenting. There may be inspissated bile, or there may be a stone in the CBD. Then you'd need to do a biliary tract irrigation. Viruses, commonest is CMV. You may get bacterial sepsis causing neonatal cholestasis, and then you need to give antivirals or antibacterial agents. Toxins, parenteral nutrition, especially if you have a soy-based formula, then it can cause cholestasis due to intestinal failure associated cholestasis, especially in preterms. Then you need to change your formula, give a formula which does not contain soy formula. Endocrine causes, you may have hypothyroidism, hypopituitarism. Then there may be genetic causes. Don't forget galactosemia, tyrosinemia, hereditary fructose intolerance, cystic fibrosis, and bile acid synthesis defect. So all these are treatable causes, but then there are still other causes that you have to keep in mind. In the Western world, we think of alpha-1 antitrypsin. We don't see this in India, so don't even send these tests in India. Alagille syndrome, bile duct paucity, the syndromic variety of bile duct paucity. Nowadays, more and more we are picking up genetic causes, especially since we've started sending genetic testing, and we see a lot of these neonatal cholestasis are actually PFIC, almost 10%. I will come to discussion of PFIC later on. We also have GALD as one of the causes of neonatal cholestasis. I'll be discussing that too. And then you have these idiopathic neonatal hepatitis where you don't have a cause. But with genetic testing, we are finding out more and more mutations, especially these heterozygous mutations in the bile transports, and that have been reported as idiopathic neonatal hepatitis. But then the disease pattern is evolving, and so we find that the incidence of idiopathic neonatal hepatitis is actually going down. Rare causes, if you have multisystem involvement, if you have a CNS involvement or a diarrhea, think of mitochondrial. You could have congenital disorders of glycosylation. If there is an abnormal skin, ichthyotic skin, or you have very woolly hair, different kind of hair, then think of neonatal ichthyosis sclerosing cholangitis syndrome, niche syndrome. Rarely trisomy 21 can cause cholestasis. And then you have neonatal sclerosing cholangitis itself as a cause of neonatal cholestasis. Other rare causes, bile acid synthesis defect. So you could have these conjugation defects, very rare, but again they are treatable causes. And then you may have metabolic disorders like urea cycle defects and Niemann-Pick type C and lysosomal acid lipase deficiency. So you can see there's a whole list of causes, and if you land up investigating for each and every cause, it will be an extremely expensive affair. What I'm going to concentrate is on common causes that we see are the causes of neonatal cholestasis, briefly describe them, and then how do we approach them. Now, if you look at data from our center, neonatal cholestasis, we find that 42% of the neonatal cholestasis were actually biliary atresia. Very few, 6% was around sepsis, and then 51% was actually other causes of neonatal cholestasis, which included PFIC, Tyrosinemia, galactosemia. It could be Alagille syndrome, it could be Choledochal cyst. So various different causes which were in the intrapet, but the predominant chunk was biliary atresia. How do you go about this? So if you have onset of jaundice within the first 2 weeks, then your diagnosis is usually biliary atresia, whereas most of the other hepatocellular causes come after the second week of life. Now let's discuss some of the common causes of neonatal cholestasis. So first let's talk about prematurity. With a lot of preterms being in the NICU, surviving, so many times you'll get a reference from the NICU for cholestasis. But remember, in prematurity, the causes of cholestasis are multifactorial. One, it's because of infections, so keep in mind sepsis as one of the predominant cause. Second, because the premature infants are not being fed orally, so they don't have stimulation of the gallbladder. That may lead to stasis of the bile, and that may appear as cholestasis. So there is absence of enteral feeding and gallbladder stimulation. Premature infants sometimes are on ionotropes, they are in shock, there may be hepatic ischemia because of hypertension. They also have NEC, they have intestinal injury, inflammation, that itself can cause cholestasis. Certain medications, like they may be on antivirals like CMV treatment, or they may be on antifungals like voriconazole, and those can cause hepatitis and liver injury. And as I mentioned, parenteral nutrition, especially soy-based formula. Remember, in a premature infant, even with clay stools, don't think of biliary atresia, because biliary atresia usually is a full-term child, well-grown, and clay stools, not in premature. Now let's come to biliary atresia. Biliary atresia is an obstructive cholangiopathy of unknown etiology. A lot of times in mice, they found that rotavirus is supposed to be one of the etiological factors. We found CMV as one of the etiological factors. So the etiology still remains unknown. It may be embryonic variety, which may be syndromic, where you may have polysplenia or situs inversus, or you may have just a non-syndromic form, which is the commonest cause. These patients are usually well baby, normal birth weight, and growing well. They have clay stools. The non-syndromic form is around 84%, and the syndromic form is around 16%. Usually these kids are missed because they are normal looking, they are well children. It's only when they go for immunization, first immunization at say 1.5 or 2 months of age, that's when the pediatrician picks up that this child is jaundice, and that's when they are picked up. Why it is important to have a right time of diagnosis? Because the surgery, if it is done within the first 60 days of life, 70% of these kids will establish bile flow. And after 90 days of life, only 25% will establish the bile flow, and they will fail the surgery and they'll land up for liver transplant. In fact, most of the patients who are referred to us are usually late. They come to us at 2.5 months of age. And when we post them for Kasai spontoenterostomy, we tell them 30% chance that there will be jaundice-free after the surgery, 30% chance that he will still develop a chronic liver disease, and 30% is he will not be jaundice-free and he will require transplant later on in life. Now, biliary atresia is very much dependent on the color of the stool, on your history. So always keep this stool card in your phone. It's an image that you can download. Ask the parents to identify the color of the stool on the chart. So number 1 to 6 is basically clay colored, and 7, 8, 9 are usually normal colored. So parents would tell you yellow stools because they have not actually thought that this is clay colored stools, but when you ask them on the chart, they reply to you. Also ask the parents to click a photo, or you look at the stool yourself. If the parents can click a photo of the stool and you see the color, you will also come to know whether there is clay colored stool or not. This is the most important thing to identify biliary atresia. Biliary atresia, the commonest type is your type 3. You have 3 types of biliary atresia. Type 3 is where there is atresia of CBD, CHD, the entire extrahepatic drugs, including the porta hepatis. And this is what happens when you do an intraop cholangiogram. The dye does not pass down, does not go up, and the gallbladder is atretic. Type 2 is when you have atresia of the CBD and the CHD, but the porta is patent. And type 1 is the cystic variety, in which the proximal ducts are patent, but there is atresia of the CBD, and the CBD is usually cystic. The gallbladder will contain bile. So when you do an intraop cholangiogram, you find that the dye doesn't go down, but it goes up. So even this variety you have to keep in mind. There is an entity known as CMV IgM positive biliary atresia. We've been seeing a lot of this, and in fact 18 years back we used to we didn't really have PCRs in the liver tissue at that time, so we used to do blood PCRs, identify these patients, put them on ganciclovir, because at that time we didn't have valganciclovir. But now we've identified that these patients tend to have a higher bilirubin, they have higher AST levels. When you do a liver biopsy, usually biliary atresia will show bile duct proliferation, bile plugs, but in these patients you'll also have inflammatory infiltrates in the extrahepatic biliary apparatus, and even your liver CMV PCR will be positive. We've in fact done a lot of study on this entity, where one of my students first had a thesis on looking at the liver PCR CMV, and we found that these patients, you had a CMV PCR even in the liver positive. We looked at the cytokine response in the liver, and we found that the TNF alpha, interferon gamma, is elevated in the liver tissue. We also looked at the gut microbiome in these patients to see what is happening, and we found all these CMV patients used to have a low bifidobacterium and low butyrate levels, and maybe this dysbiosis was the cause of causing all the problem. So we've been treating these patients with valganciclovir because there is an organ damage due to CMV, and we are now looking at the dysbiosis part and seeing how we can correct the dysbiosis to decrease the atretic area of these patients. CMV tends to afflict the bile ducts. Even in your transplant patients or bone marrow transplant patients, you have something known as vanishing bile duct syndrome with CMV. So it has a predilection for the bile ducts, and it is important to identify these patients because you can treat them with antivirals, especially valganciclovir. Now this is the histopath of the bile duct proliferation, and you can see giant cells, but these giant cells are basically non-specific. You can see it in a lot of neonatal hepatitis conditions. So it's not specific for CMV or it is not specific for biliary atresia. In any neonatal cholestasis, you will get giant cells. So how do you diagnose biliary atresia? Basically, there's no single test. You do an ultrasound. The moment you get clay stools in a well child, you do an ultrasound, rule out choledochal cyst, rule out biliary atresia. In case of biliary atresia, you will find that the gallbladder is either absent or a pre-feed gallbladder will be small and it will show a lumen which is less than 1.5 centimeters in length. Then you look for triangular cord sign, which is a solid biliary remnant at the bifurcation of the portal vein. You look at the porta whether there are any cysts over there. And the other sign is when you do a post feed, there should be there's no enlargement or contraction of the gallbladder after feeding. So the gallbladder is actually static in nature. HIDA scan. Now the problem with HIDA is you need 7 days to do this test. You will prime the patient with phenobarbital and ursodeoxycholic acid for 5 days. 6th day you will inject the tracer, the radionuclide dye, and then on the 7th day, 24 hours later, you will look for excretion into the intestines. So it's a 7-day test. Usually, by the time the patient is referred to you, it's too late to do this test because each day is precious, especially if you're thinking of biliary atresia. If you have a child who comes at 1 month of age, you can do this test, but otherwise I would say that be careful of when to do this test. Another thing is, if you have lot of high bilirubin, then there's a chance that it will give you false positive or false negative rate. And this is our data which I want to show you where we did for biliary atresia, neonatal hepatitis. The dye uptake was good in biliary atresia. It was 94% in neonatal hepatitis. But if you look at the excretion of the dye, there was no dye excretion in neonatal hepatitis to the tune of 40%. So if it's no excretion, it still does not mean it's biliary atresia. It could still be neonatal hepatitis. But if there is excretion, then you rule out biliary atresia. What about MRCP? It's very radiologist dependent. It needs a lot of accuracy, and these bile ducts are small and you need to sedate the patient, and resolution is also not good at a young age. So it's not really useful in diagnosis of neonatal cholestasis. And then there are these newer studies which says that you could do MMP7. It's a serum marker at 1 to 2 months of age, and it can find out biliary atresia from other causes of cholestasis. We don't do it in India, so I really don't know how reliable these tests are. This is the reports that I've quoted from the West. So for us, surgical exploration or IOC remains the only method for diagnosing and treating biliary atresia. So what we tell patients, the moment we do an ultrasound, we have a patient who comes with jaundice, clay stools, we do an ultrasound, we find gallbladder small or no contractility of gallbladder, or we find the length to be low. Depending on the age, if we have time, we go ahead with a liver biopsy, look for bile duct proliferation, bile plugs. If we don't have the time, the child is come at a borderline 2.5 months, 3 months, we straight away post the child for intraopcolangiogram. And we tell the parents that this is going to be a minor surgery. And on table, if they find that there is no flow of the dye, then they will convert it into a major surgery, which is known as Kasai's portoenterostomy. So there's not going to be a second surgery. In the same sitting, the surgery will be made it into a major surgery. So that's in short about biliary atresia. You have choledochal cyst. Choledochal cyst, what the patient will come to you is basically a lump on the right side of the abdomen. Ultrasound may pick up a cyst, and when you do an MRCP, you will find the various types. You may have the Stodanese classification of the various types. And if you have these, except for type 5, in which you can't do any surgery, these other types can be operated upon and the cyst can be removed. What about Alagille syndrome? Alagille syndrome is syndromic paucity of bile ducts. You have other non-syndromic causes of paucity of bile ducts. And the genetic mutation is basically in the JAG1 gene and the Notch2 receptor. They have very dysmorphic features in the sense they have a broad forehead, deep set eyes, and pointed chin, giving it a very triangular appearance. In the eye, they have posterior embryotoxin. There may be cardiac anomalies. There will be butterfly vertebrae. The kidneys may be involved. There may be renal cysts. There may be pancreatic insufficiency, there may be CNS aneurysms, and they have a very high risk of HCC. How do you manage them? Just supportive treatment, and they will require transplant later on in life, but not immediately. Again, when you post a patient for transplant, you have to look at the extrahepatic manifestations and decide also the mutations, because the prognosis is different for both the mutations. So this is a photograph of a child with Alagille syndrome. I've taken it from their Alagille syndrome website, standard of care website, and I've not put any photo of an Indian child because of other issues. So you can see a broad forehead with chin pointed, giving a triangular face appearance. Now PFIC, progressive familial intrahepatic cholestasis. Basically, it's a bile acid transport defect, and you find, we used to call 3 types, type 1, 2 and 3, but now with more and more mutations being identified, you have almost got 10 types of PFIC now. And these are the papers that were based on the multicentric Indian registry of PFIC that we have, of which our center is also one of the center, and various clinical genotype and phenotype correlation of these various mutations. So earlier we used to say there are 3 main types: PFIC gene mutation, the BSEP mutation, that is type 2, and you had MDR3 mutation, that was type 3. But now 3 additional PFIC types have been identified, that is your TGP2, FXR and MyoFB mutation, and plus the other mutations which are rare. What is important among all these 6 types is to remember that most of them come to you as neonatal cholestasis with low GGTP or normal GGTP, and they have excessive itching. Except for type 3, that is your MDR3 mutation, which has elevated GGTP, all the others have low or normal GGTP. Type 1 will also have diarrhea. In fact, that is one of the contraindications for doing a transplant, because the diarrhea does not stop with the transplant. So they have severe diarrhea. When you have neonatal cholestasis with diarrhea, think of PFIC type 1, think of type MyoFB, that is your type 6, where you have a microvillus inclusion disease. Think of mitochondrial hepatopathies, which can come with diarrhea, CNS manifestations, and neonatal cholestasis. So type 1, type 2, low GGTP, type 1 with diarrhea, type 2 without diarrhea. Type 3, elevated GGTP, usually comes in adulthood or childhood. TJP2 usually and your FXR gene are rapid course. TJP2 also has a neurological problem, and your MyoFB also has a microvillus inclusion disease causing watery diarrhea. Now all these patients present to you in infancy with jaundice and pruritus. Pruritus is one of the most marked feature of PFIC. Pruritus is also a marked feature of Alagille syndrome. These intractable pruritus was once upon a time an indication for liver transplant, or it was an indication for biliary diversion surgeries, where it was hypothesized that if you remove the bile acids from the intrahepatic circulation, then the pruritus can be taken care of. But now you have these IBAT inhibitors, maralixibat and odevixibat, which inhibit the transport of the bile acids from the gut back into the intrahepatic circulation and can take care of the pruritus. These drugs are available in the Western world. In India, we get it through compassionate use. And if you can use these drugs and control the pruritus, then you may be able to defer the transplant for some years in these patients. Bile acid synthesis defect, it's basically the problem in the creation of the 2 primary bile acids, cholic acid and chenodeoxycholic acid. And so abnormal bile metabolites are accumulated, cholesterol is accumulated, and these can cause fat-soluble vitamin deficiencies, can cause progressive neurological disease. How do you identify these patients? Again, they come to you as neonatal cholestasis with low or normal GGTP, a biopsy that shows giant cell hepatitis, and there is absence of pruritus. So you've ruled out biliary atresia, but they come like this. You look at the serum bile acids or a urine bile acids, and you do a bile alcohols by mass spectroscopy. Confirmatory test is by exome sequencing, and treatment is bile acid replacement therapy like cholic acid and chenodeoxycholic acid. Now, a little bit about GALD, gestational alloimmune liver disease. It's one of the causes of neonatal liver failure. That is the liver failure that occurs in children less than 30 days of life. So you have coagulopathy, which is non-correctable by vitamin K. And other causes of neonatal liver failure is basically galactosemia, tyrosinemia, HLH, mitochondrial hepatopathies, and viral infections. How do you identify GALD? A child who is otherwise looking very well but is deeply jaundiced. Deeply jaundiced. The jaundice may be up to the tune of 25 to 30. Has got ascites, but otherwise is doing well, sucking at the breast properly, not sick looking, and severe coagulopathy. Your INR could be somewhere around 4, 5. So the parameters look abnormal, too dangerous, but the child looks well. So this was a table I found very useful, where different etiologies of neonatal ALF and how to identify them. So if you look at GALD, they are mostly premature babies. There is a history of a maternal sibling death. There is oligohydramnios, IUGR. But the most important is ascites and profound coagulopathy and very deep jaundice. Viral infections, usually they are having a lot of hypoglycemia. HLH, you will suspect when a child comes with fever, pancytopenia, and jaundice, and you will all of these conditions will have a ferritin which is pretty high. In HLH it will be almost to the tune of 20,000 plus. When will you suspect mitochondrial hepatopathy? When there is associated CNS involvement or heart involvement, lactic acidosis, and the transaminitis is pretty high. So what is the pathogenesis of GALD? The pathogenesis is basically during gestation, there's maternal exposure to the fetal hepatocyte antigen that leads to an alloimmune attack, activating the termin and complement cascade, causing death of these developing hepatocytes. How do you diagnose? You look at the serum ferritin, it's elevated. MRI or the buccal to look for iron deposits in the pancreas, spleen, in the liver. Look at the buccal biopsy for iron deposition. Treatment is double volume exchange transfusion. Remove the existing antibodies, high dose IVIG, block the antibody-induced complement activation, and if still the patient does not improve, the treatment is liver transplant. A little bit about tyrosinemia. Tyrosinemia have large kidneys on ultrasound. They also are causes of coagulopathy, and they have metabolic acidosis. They usually cause neonatal liver failure. So when do you suspect anybody on an ultrasound who has large kidneys, think of tyrosinemia. In older children, they'll come with rickets and hepatomegaly. Diagnosis is elevated alpha-fetoprotein, but don't do an alpha-fetoprotein in neonates because it's going to be high and you won't know how to interpret it. The best way to diagnose is to do a plasma tyrosine levels and a urine succinylacetone. Obviously, you can do the genetic test, but these two tests are more than enough to diagnose tyrosinemia, and treatment is diet restriction and tyrosine. You get specific formulas for tyrosinemia, which are tyrosine depleted formulas, and NTBC, and NTBC is now available in India. So there are certain clues for neonatal cholestasis, and if you look at the history, you will get certain clues, like you will have maternal history. If there's a history of cholestasis during pregnancy, itching during pregnancy, think of PFIC or a mitochondrial. If she's had repeated fetal loss, think of GALD. If there's infection during pregnancy, she's had fever, then think of congenital infection. When you examine a child, you find acolic stools, you think of biliary atresia, choledochal cyst, gallbladder sludge, gallstone. If there is a mass in the right hypochondrium, think of choledochal cyst. If there are murmurs in the heart, think of Alagille syndrome, congenital infections, biliary atresia, butterfly vertebrae, again Alagille syndrome. If you have ascites, think of perforation of the bile duct or GALD. If you have dysmorphic features, think of Alagille syndrome. And if you have microcephaly, congenital infections, posterior embryotoxon in the eye, Alagille syndrome, chorioretinitis, think of infections, cataracts, think of galactosemia and infections. Splenomegaly, usually you would not get splenomegaly in neonatal cholestasis, but if you get a spleen, think of a storage, think of CMV, think of portal hypertension if the child is more than 4 to 5 months of age. So don't forget on your history to ask about passage of meconium. If there's delayed passage, think of cystic fibrosis. Urine color, stool color, maternal fever, jaundice, itching, family history of liver disease, and consanguinity. On examination, never forget to do an eye examination, a hearing test. Look at dysmorphisms, look at growth. If growing well, it's usually biliary atresia. Ill looking, maybe infection or metabolic. And a cardiac examination for Alagille and biliary atresia. So what test are you going to do? Well, you're going to do some general essential tests, like you want to do a complete liver function test with a GGTP, a PT-INR to identify coagulopathy, low GGTP. Look at the CBC to pick up infections. If there is low or normal GGTP, you think of PFIC type 1, 2, TJP deficiency. Thyroid function test, if it's not been done in the newborn period. Urine reducing substance to pick up galactosemia. If the child is sick looking, you will do cultures of the blood and urine and a fasting ultrasound. So these will be your baseline tests. Based on the baseline test, you may do further tests that are required, specific tests. Now, what are these specific tests? Bile acids would be done for PFIC. You would do for bile acid conjugation defects. You may do ammonia, lactate levels, cholesterol, GALT, succinyl acetone, organic acids for any metabolic disorders. Then you may, for infections, do PCR for CMV-HSV. For genetic disorders, you'll send an exome sequencing. For GALT, you will do a serum ferritin. Same thing for HLH, you may do a serum ferritin, buccal biopsy, MRI. Then echocardiogram, liver biopsy, and a cholangiogram. So how do you approach these patients? This is a guideline by the Pediatric Gastroenterology chapter of IIP. It's a pretty old guideline which needs to get updated now. So you look at neonatal cholestasis and look whether the child is sick or not sick. If the child is sick, they are basically going to be in the NICU. You'll get a reference from the neonatology team to look at this child. They may have already done the sepsis screen, and if sepsis screen is positive, you first treat that before you do anything else. Only thing is just do a urine reducing substance so that you don't miss out galactosemia. If the sepsis screen is negative, then you look for other causes of why the child is sick. You look for viral infections like CMV, HSV. Look at metabolic causes like galactosemia, tyrosinemia, GALT, and HLH. And if all that has been ruled out, then look at the ultrasound. And if you find gallbladder is less, you may do a liver biopsy, or you may straight away send for a exome sequencing. If a child is not sick and there is pale stools, then look at this gallbladder on the ultrasound, and you may pose for liver biopsy or an IOC, depending on the age that the child has presented to you. If there are pigmented stools, then you may consider liver biopsy, genetic test based on your history and examination, and consider specific treatment. So this is another algorithm that I found from the Western world, in which they now look at neonatal cholestasis based on the definition. They would always check their patients for alpha-1 antitrypsin, which we don't need to do for India. They would rule out sepsis, and cultures would be sent, a newborn screening for galactosemia, tyrosinemia, hypothyroid, ultrasound, and if there are red flags for specific etiology, then the workup would go on to that. And if none of it is positive, a liver biopsy, cholangiogram, biliary atresia. And if that doesn't pick up anything, then you may do a genotyping. You may do either a VES, you may do clinical exome, or you may do a whole genome sequencing based on what you are comfortable with. And treatment-wise, you are supposed to give all the fat-soluble vitamins because of malabsorption. So you give ADEK in water-soluble forms in 10 times the recommended daily allowance. So you can give vitamin K either oral tablets, or you can give injectable monthly based on what you are comfortable with. Cholecalciferol, you can give it as syrups. Now, just be very careful with the syrups because they are oil-based solutions. So if you want to give a water-based, you need to give a sachet, which is granules. You may give it once a month, or you may give it orally into pulverized forms. Vitamin A, because you don't get anything available beyond less than 25,000 international units, so you can take a capsule and give it once in 4 days of vitamin A. Vitamin E, again, you get it in a capsule form. And then you have to give these water-soluble vitamins, which are twice the RDA levels. Don't forget to give MCT oil. And if the child has pruritus, you will give ursodeoxycholic acid, rifampicin, phenobarb, cholestyramine based on the amount of itching that the child has. Don't forget about IBAT inhibitors for PFIC and Alagille. So I would like to conclude saying that a careful history and a thorough physical examination, serum bilirubin is recommended in any infant with jaundice seen after 2 weeks of life. With the advent of genetic tests available, new genetic defects have been identified, and the incidence of idiopathic neonatal hepatitis is going down. We are picking up more and more causes. However, biliary atresia still remains the commonest cause of neonatal cholestasis, and early diagnosis leads to better outcome. And your approach to how to diagnose this patient will be based on clinical and physical clues. Thank you very much.